Bom dia a todos, sejam todos bem-vindos ao Grande Round, esse evento que é uma parceria das diretorias médica e de ensino do HCPA e da Faculdade de Medicina da URGS. Hoje temos a honra de contar com a participação da doutora Fernanda Bellolio, médica emergencista e professora titular do Departamento de Emergência da Clínica Maio, da doutora Juliana Zanettini, médica do Serviço de Emergência do HCPA, e doutor Lucas Oliveira, médico residente do Serviço de Emergência do HCPA. A Fernanda nos falará, então, sobre a medicina de emergência, uma especialidade por si só. Ela é professora titular de medicina de emergência do Departamento de Emergência da Clínica Maio, chefe de pesquisa do Departamento de Emergência da Clínica Maio e é uma das lideranças das diretrizes da Sociedade Acadêmica de Medicina de Emergência. Possui mais de 150 publicações em revistas de alto impacto, como New England, Annals of Emergency Medicine. It's a great pleasure to have you here, Fernanda. Please, if you want to start the lecture. Thank you very much for coming.
I'm really excited to be here. I know my name is Fernanda and I should be able to speak Portuguese, but I don't speak Portuguese, so I'm sorry I'm going to be speaking in English today. So I'm a professor of emergency medicine, but I'm also a professor of health science research and a professor of medicine, specifically in the area of geriatric medicine. We can only have 3 professorships, otherwise I will have more if I could, because I think it's really important that we collaborate with other specialties. And I'm here today to tell you why emergency medicine should exist. Not only why, but how also. So I want to say that, first of all, it's incredible and it's an honor to be here in Porto Alegre today and see how emergency medicine is growing. So emergency medicine started in the United States 50 years ago, and coming here today and see how this is growing and how it's like you have so many leaders here, it's actually inspiring. I want to say that the story repeats itself. So the same thing that happened in Europe, in the United States, is happening here now. But you have the advantage that you know how it ended already in other places or how it's going. So you can do it even better, because you can learn from our mistakes and make it work here. So for example, Porto Alegre is really going to be the pioneer in emergency medicine in Brazil, and you can do that. And the way you can do it is because you have the power to make the right decision right now. You do not need to wait for more time to pass. You really need to open the door to have emergency physicians teaching other emergency physicians. Your professors have to be emergency physicians because it's a different specialty. And we're going to talk today about what is a specialty and what is emergency medicine. So let me get to the next one here. So the things we're going to talk today are what is emergency medicine, the story in the United States, how do we practice emergency medicine today, if it's cost effective. We're going to talk about education and research, because those are really important areas of a specialty. We're going to talk about the challenges that we have in emergency medicine and also the future. This is a picture of our trauma area, where one of the instructors is teaching the residents, showing where the trauma items are in the trauma bay. So most of the pictures that I'm going to have today are from my emergency department, and I will try to put that into context here too. So what defines a medical specialty? So everybody here has a specialty, could be different ones. So a medical specialty is a type of work that somebody does the most, or does best, or know in depth. So it's a clinical discipline with 4 essential features. It's a unique field of action, it's a defined body of knowledge, and it's an active research program and training program. So you need to have those 4 things to have a specialty, no matter what that specialty is. So what is emergency medicine? And the one in the back is my hospital, and the emergency department is, let me see if I can show, yeah, that triangle here is where the emergency department entrance is, and up here is 9 floors with 9 ICUs. Each floor is a different ICU, and they're immediately above the emergency department. So emergency medicine is a medical specialty that's focused on the diagnosis and treatment of any acute and life-threatening condition. We care for anyone, meaning young and old, rich and poor, with trauma or with a heart attack, We care for anything that comes through the doors of the emergency department. It could be someone that's vomiting blood, or it could be somebody that has an ankle sprain. And we care for them at any time. That means in the day, night, in the week or the weekend. We even work over New Year's. So this is one of our nurses here, one of our pharmacists, and one of the residents here. So these are three of the people I work with every day. So emergency medicine is a vital component of the healthcare system worldwide. Not only in the United States, not only in Brazil. The complete world needs this, and this has been said by the World Health Organization. So physicians are trained to provide a rapid assessment, resuscitation, and stabilization of the patients that need immediate attention. That's what we do in the emergency department. So that's not my emergency department, but it's a picture about an emergency department. So this is a picture where we have the faculty getting airway training. Every year, we train all our emergency physicians and our residents and our nurses, a group of nurses that are called kind of nurse practitioners in airway. So you can see how we have, this is the simulation. So really similar to the simulation that I just toured here. Everybody has a different airway, and these airways are all different from each other. So each model is different, and they're all with different complications. For example, one of these models have a large tongue that is more difficult to intubate. One might have a very anterior glottis, so you cannot see the epiglottis as well. So they're not like one same to each other, so you actually have to intubate them all because they're all different. So I think I was already saying this, but it really requires a unique skill set in emergency medicine. You need to be adaptable, and you need to handle high-stress situations, always being professional and with empathy, too. So what's the story of emergency medicine in the United States? So post-World War II, there was a need for specialized care. And we were looking at patients with mostly trauma and critical injuries. So this is many years ago. And then in the late 1940s and early 1950s, there started to appear accident rooms that were places to address the growing demand for emergency care. Then in the 1960s, the emergency departments were recognized as a safety net, meaning a place where the patients could go when they needed care. For example, if you had a patient with a kidney transplant that now has a fever, where will that patient go? Or if you have a patient that has abdominal pain, they do not know if they have a surgical condition or not. So you need to have somebody that can see all of these patients and then see what the resource needs to be allocated and where. So in 1968 is where in the United States, the American College of Emergency Physicians was founded, kind of similar to what will be a RAMIDI here. And then we started having standardized training and education. And this is key for all specialties. You have your own training, education, curriculum, and research paths. And this was really a turning point in recognizing emergency medicine as a specialty. And this, again, was in the late 60s in the United States. Then in 1970 was the first recognized emergency medicine residency in Cincinnati. In 80s, they continued to grow and be recognized across the country. And finally, in 1986, there was a rule that says that even if you could not pay, you should be seen by a doctor in the emergency department. And this was really important because many times the patients that are carrying the emergency department are the ones that no one else wants to see. The uninsured, the older, the homeless. And they need to receive care too. So the emergency specialty continued to grow in the United States, and in 2020, we had almost 270 emergency medicine residencies in the United States. And what's really interesting for us, and you also have the same privilege right now, is that the first generations of emergency physicians are still alive. So there's a living memory of how was emergency medicine at that time and how it is today. So this is one of our residents intubating, and there's another resident on the left trying to help her with the intubation. So the American College of Emergency Physician definition of emergency medicine is the initial evaluation, diagnosis, treatment, and disposition of any patient that requires expeditious medical, surgical, or psychiatric care. So the World Health Organization called for the involvement of ministries of health in the review and strengthening of trauma and emergency care. This was in 2007, and it was a call for all countries to develop an effective emergency care system. This was in 2007. And then in 2019, they repeat a similar publication that says that emergency care systems for universal health coverage are a priority of care for all the health systems around the world. So this is my emergency department. This is the entrance, and you can see how the helicopter is coming. So the landing is in the same building where all the ICUs and emergency department are. So these are also two of my residents, Julie and Eric, and they're having a Lucas device to help facilitate the chest compressions that I know you have here. And we have one of our simulations here. So I was saying that it's actually very similar, the technology that you have here. So they're teaching each other. So in the United States, we have around 150 million of emergency department visits for a population of 330 million. So in Brazil, that we have around 220 million, we will expect 100 million visits to the emergency department. Overall, this is all the United States, not my hospital, but 14% of the population will need to come into the hospital, and this includes children that are less likely to be admitted. 30% of the adults are admitted, and 50% of those 70 and older are going to be admitted. That's every 2 patients, one of them will need a hospital bed. So this is my hospital. Again, I said I'm going to put my pictures here. So it's a really large building. The emergency department is in this area. This behind is the psychiatric area, so it's a psychiatric hospital. And the ambulances come this way, you enter to the emergency department, and then all these are different ICUs. A pediatric ICU, a neurological ICU, a trauma ICU, a surgical ICU, another medical ICU. So we have a lot of specialized acute care. When the patients need admission, they immediately go to that ICU. We do the first assessment, we intubate them, start the ventilation, the pressors, and then they go to the team that will take care for them, because that's their specialty. Sure. That's good. So our emergency department has, you can go back one. So we do have 75 patient care rooms. So we have 75 rooms where we can see patients, and we see 80,000 patients a year. So that's around 200 to 250 patients per day. And they're seen by 55, not 55 at one time, but we have 55 faculty professors of emergency medicine that work in that emergency department. And we have 30 residents, emergency medicine residents. So out of our 80,000 patients, we also see children. It's around less than 20% of the volume of what we see are children. And we're trained to see both, adults and children. So I do see both. I work in both areas, day and night. We are also a trauma center and a stroke center. That means you don't need to go to another hospital to be cared for when you have a trauma. You don't need to go to another hospital when you have a stroke. You come to this center, we make your diagnosis of stroke, we initiate the thrombolysis, and then you will be admitted to the neurology floor. The same for the trauma. We assess that patient with a trauma, and then you get admitted to the trauma with the trauma team. And I'm going to give more examples later. Next slide. So what defines the practice of emergency medicine? These are the main components of what emergency medicine is. We have an acute and unscheduled care. People don't make appointments to get sick. People don't make appointments to have an accident. This happens acutely. So we care for patients who have a sudden, severe, potentially life-threatening condition. This could be a trauma, could be a heart attack, could be a stroke, could be an infection, could be a respiratory distress, could be other medical issues. But we don't know, and they don't know what they have before it happens. We do have a team-based approach. What this means is that emergency physicians work really closely with other healthcare professionals. We rely a lot in our nurses who are at the bedside. We rely a lot in our other specialties who might refer patients to the ED because they trust that we will provide good care for them. So if I'm a surgeon and I'm in the operating room and one of my patients has a complication, I want them to go to the emergency department because my colleagues, emergency physicians, will take good care of them. And then we will involve the surgeons when it's needed. Emergency medicine is also defined by rapid decision making. We need to make critical decisions and really quickly, and many times we do not have a lot of information. Patients could come even without a name. You don't know their name, their age, if they were involved in a trauma, so you don't really have all the information you want to have. But even with that little information, you need to make decisions in advance. We have a very diverse patient population. Because we see every patient that comes through the door, so we cannot say no to provide care in the ED. And also we see from infant to elderly. And then we have a very broad knowledge base, meaning we need to know a lot of many things. We don't need to know the same depth that a cardiology will know about a heart attack or like a hypertrophic myocardiopathy, but we need to know a lot about all the chest pains and which one of those 100 chest pains is the one that will have a STEMI. Which one of those 100 patients is the one or two that will have a non-ST elevation MI or a myocarditis. We're really good at making diagnosis or at least risk stratify. Sometimes we might not know what is the cause of that chest pain, but we know what is not. So you're coming with chest pain. I do not know why your chest is hurting, but you're not having a rib fracture, you're not having pneumonia, you don't have a pneumothorax, you don't have a heart attack today. So we feel it's safe. We have risk stratify. You could go home today. And we're really good about doing this initial stabilization and management, meaning that we initiate the treatment, the stabilization, and then the patients will go where they need to go. We call this disposition. You go home, you come in. You know, it's like almost like two options. So we can go next one. So I really want to emphasize, and this is also 3 of the residents that are working with us right now, what emergency medicine does the best is care for these undifferentiated patients that come at all hours of the day or night. We're really good at risk stratify and also rule out life-threatening issues with very limited information and time. Next. So this is me with 3 of my colleagues. So we're all faculty, professors, and you can see how we have somebody on their 30s, somebody on their 40s, somebody on their 50s, somebody on their 60s. We're all emergency physicians getting trained, learning from each other. So here we're learning how to do a new type of arthrocentesis of the ankle, like how you take the fluid from the ankle when you think could be an infected joint. But we teach each other, and we're faculty, and we never stop learning because the science of emergency medicine moves too fast, so we need to be up to date. And I think this is something that I feel is important to highlight, and I really enjoy my time educating among ourselves. We actually don't have a lot of time to hang out with my friends, and I think this is a good way to do it, just through simulation. This is in our simulation center. We're just teaching each other. So this is a picture of the emergency department. Let me see where I was here. So we have individual rooms. We have 75 rooms. So these are the hallways. Of course, we took the picture when no one was there. These are the hallways, and for Pedrolo, there is an ultrasound machine in the hallway. Here for you. And so patients will come, be in the room, and radiology will come to the room to take their X-ray. Laboratory will come to the room to get their blood. The urology technician will come to the room to place a Foley catheter. So patients stay there. Things will come to them. We don't have a CT in the room. They will go for a CT, but we have 4 CTs only for the emergency department, and they're like just across the room in the same floor. So we have a central pod or central area where we have that person in blue that is kind of a secretary that helps placing the appointments for the follow-up or calling other services that we need to talk to them. And all those computer desks are the area where the nurses and the physicians sit together, because we all work in teams, and we care for the patients. Next one. So what type of patients we see? And this is one of our residents that is caring for a simulated patient. So the daughter of one of the faculty that was able to gracefully agree to be our sim patient for the pictures. So we care for every single chief complaint. We look at for people with abdominal pain, with chest pain, with an ankle injury, a child with a fever, somebody that wants to kill themselves, suicidal ideation, patients that have vaginal bleeding, people with an eye pain, people with confusion, people that are agitated, a drug overdose, a shoulder dislocation, somebody with a seizure, a car accident, somebody that's short of breath, somebody that feels weak that day and they cannot walk anymore, cannot leave the bed, somebody that's homeless or hungry or drunk or cold. Next one. Next one. So this is one of my residents doing a lumbar puncture. So the residents are trained to do multiple procedures. They're experts in doing procedural sedation, so sedating the patient in the emergency department so we can put, for example, a chest tube. They're really good about doing bedside ultrasound. We'll be happy with that too. They're good, they know how to put a chest tube when we need to. They even train to have an unplanned vaginal delivery. We do have an obstetrics area, but sometimes the patients come and they don't know they're pregnant. And that baby can happen at any time, and we are ready to deliver that baby. Not that we are the best ones doing it. OB is far better than us. But if that patient comes to our door, we need to care for them and for the baby. They know how to do lumbar puncture, intubation, resuscitation, defibrillation, central venous access, IV, pericardiocentesis, cardiac pacing, toxidromes, and many more things. What if the patient was involved in a car accident? Well, most of the patients involved in car accident do not need a surgeon, but some do. And the ones that do, we call the surgeon once it's needed. We first get the IVs, we are sure that they have an airway, we take some x-rays, CTs, we do our FAST exam to look if they have free fluid, and if the patients are unstable, the trauma surgeons will be coming to the trauma bay. And it was interesting discussing earlier today that we do train every month with the trauma surgeons in the same room. We go to our simulation center and we discuss like how we will communicate with this patient. So we do what we call team training, because we work with emergency physicians all day, but we also have to work with our colleagues. They don't want to be called for every single car accident. They only want to be called when we need them. Next one. The same if somebody has like appendicitis. We see 100 abdominal pains and 2 will have appendicitis. You don't need a surgeon sitting there seeing all these abdominal pains that could be a gastroenteritis, diarrhea. They want to be called when they need to do something, take the appendix out. Because they rather be in the OR, in the operating room doing surgeries. So what's really important is that emergency medicine is, we call it safety net. So it's where the patients can go to get care. But it's safety net not only for the patients, it's safety net for our other specialties too. If I'm a nephrologist and I'm seeing a patient in the clinic and they have a new kidney function that's terrible and they will need dialysis, where do I send them? It's hard to start dialysis just one day in the clinic. But if their potassium is 7, really high, they actually could die. So where do I send them? To the emergency department. So we're a safety net for our patients, but we're the entry door for the hospital and for our colleagues. We fill some primary care gaps, and this is different in different places, but sometimes patients might not have access to their primary care doctor to manage their high blood pressure medications or to manage their diabetes medications, and they can come with very low blood sugar or very high blood pressure that could be dangerous for them. So we sometimes fill those gaps. So we care for acute things, but we also care for when chronic conditions are decompensated. A patient with a heart failure, but now they have pulmonary edema. They need an emergency physician. Their primary care has been trying to prevent this, but now that this has happened, you need an emergency physician caring for them. We also make sometimes diagnosis of cancer. We wish this happens outside the clinic and that there was ideally prevented, or it was through just diagnosis outpatient. But sometimes somebody will come with chest pain or shortness of breath. We do a CT and you find a new lung cancer. So we also sometimes make those diagnoses. We're not the place to make that diagnosis, but they happened because we found them. And because we found them, we need to know how to interact with these patients and how to keep them safe and treat them after. Next one. So emergency medicine is defined by this time-dependent workload. We're not defined by the organ system. We're not experts in the lungs or the heart or the brain. It's just the body, and it's something acute. And we are defined, again, for this unscheduled and acute care. Next one. One more time. So this is a real patient, and I have here 2 residents and 2 of the nurses caring for this one patient. You can see how the one in the airway, Dougie, is asking for some help with he's indicating somebody else. So this is our real emergency department, again, real patient here being cared by a team. So many times it's the risk stratification more than the diagnosis what we make. But then once we define if they need to come in or not, they're going to immediately be disposition, meaning like they need to leave the ED because we made the diagnosis. Now they need an expert on the management of the inpatient. That's not the emergency physician. That's an internist. That's an internal medicine doctor. The emergency physician cares for the acute part, but then we're not the best to care for them longer term in the hospital. That's not our training. That's other people's training, and they do a wonderful job. We have fantastic internal medicine doctors. We have fantastic hospitalists that they know how to do that job better, way better than what we do. That's why once we define that somebody needs to come in, they need to go to be cared by the doctor that knows that the most. And when we have patients that we already decide they need admission, if it's more than 4 hours since decision for admission, the internal medicine doctor will come care for them in the emergency department because they are the ones that know the best what's needed for that management. So they will know what indications to put, how to manage their insulin, their diet, all this regimen, until a bed comes available and they can take them up. But they know them already because they start to care for them. So internal medicine comes to the emergency department once we admit these patients, if it's more than 4 hours. So I know that's a very short time frame. You can do 24 hours, but we need to have emergency physicians caring for the acute patients because that's what we trained to do. Next one. So emergency medicine is very cost effective. And I think this is important because even if every patient has public insurance, we still need to make the system and the hospital work. So there's evidence for several years and across multiple countries that emergency medicine is cost effective because you have the right treatment and the right resources to care for that acute patient. We can see every type of patient, so they don't need to know where to go. I cannot select, okay, I only see patients with chest pain. And also a chest pain could be a rib fracture, it doesn't need to be a heart. There's more things in the chest than the heart. It could be your lungs, could be your of course it could be your heart, but it could be your lungs, could be your pleura, could be your ribs, could be your chest wall. Even, like pneumonia can hurt in the abdomen. So like somebody with abdominal pain could have pneumonia. So we need to know where to look. We also, as I mentioned already, but we're expert on this critical initial assessment. We stabilize the patient and when we disposition this patient. So in this picture, we have also a real patient that is having the Lucas device for chest compressions, while at the same time, we have one of our colleagues from anesthesia starting ECMO. So you can see how they're accessing their groin to start the ECMO process. But in the airway, we have one of our emergency medicine residents. Behind him, we have another emergency medicine resident that is getting the transesophageal echo. So they're going to do an ultrasound of the heart through the esophagus so they can see exactly when the cannulation of the ECMO is getting to the right place. And then we have, the picture is too close, but this room has probably 20 people that are working on this single patient because we are saving his life. Next one. So there are several papers, even that we are a level 1 trauma center, there are several papers that show that most trauma does not require trauma surgery. This is good for the patient. So in the past, most people that had trauma and had a spleen laceration will get the spleen out. Now we don't do that anymore. Most of these people will stop bleeding on their own, And we actually have a wonderful radiology team with interventional radiology, and many of these bleedings can be stopped by interventional radiology instead of surgery. So one surgeon in a trauma center will do surgery for trauma patient every 7 days. So we see hundreds of patients with trauma every day, but the one that's going to need surgery is a very small minority. But they do need the specialized care that our trauma team can give once they are admitted, because they are the experts on managing the rebleeding and those needs. So as I say there, so trauma surgeries are very rare, and most transfusion, interventional radiology, or non-surgical will be enough. But as emergency physicians, we intubate, we start the transfusion, we make those decisions. We do our bedside ultrasound exams. We send them to CT. Next one. So when you have a shift without emergency physicians, you need to have surgeons, you need to have internal medicine doctors, you need to have pediatricians, you might need to have an orthopedic surgeon, all these people, so that when the one patient comes through the door, the doctors can fight who's going to see this patient and whatever the chief complaint is it. When you have a shift with emergency physicians, 1 or 3 people, depending on your volumes, can do the same job. Because first of all, we have to stratify to see what's wrong with this patient, and then we can send the right one for the surgeon, the right one for the other specialties. Because an emergency physician can see any patient that comes through the door. Next one. So this is an article written by our cardiology colleagues, where they have also emergency physician as authors. Because the regional system for the management of a heart attack depends on the door of where that patient will come into the hospital, and that's the emergency department. So again, this is a cardiology topic written by cardiology with emergency physicians that are also authors, because we need to work together and collaborate for the management of a patient with STEMI. Next one. We're also trained on bedside ultrasound, including echocardiography, for example, to rule out cardiac tamponade, wall motion abnormalities, estimate ejection fractions. We look for gallstones and other things, so it helps, again, stratify. And we write papers with colleagues from the specialties too. Next one. And other specialties learn from us too. So this study was very common, very famous, from Dr. Emmanuel Rivers about sepsis. And he's the first person that says it's really important that you start giving fluids and resuscitate early on. So he is an emergency physician. So again, this paper that changed how we manage sepsis around the world was written by an emergency physician, because he's the one that was seeing these people getting really sick in front of their eyes by the minute because they are having an infection. So we also teach other specialties. Next one. So just trying to go with some other studies. There are several studies that show the value and the efficacy of emergency medicine, including how we can improve the care for patients with emergent complaints. Next one. So what about in developing countries? Is it worthwhile? So there is a very large body of evidence that this is definitely the way to go, because it actually is much more cost conscious than having multiple specialties in the emergency department. But not only that, it's also better for patients. So we have great physicians in other specialties. Why we need emergency physicians if we already have good internists, if we already have good surgeons? Because we do something different. We are not trying to compete or take away the space that other specialties have. We have our own acute care specialty. So also the patients do not know where to go. Why is the decision on them? No matter where you go, an emergency doctor can take care for you and should take care in the same way in any emergency department. Next one. So just to emphasize again that as a surgeon, you will rather be in the operating room doing surgeries because you want to be proficient. You want to do many surgeries. You don't want to be seeing non-surgical abdominal pain in the emergency department. The same as dermatologist or orthopedic surgeon, you don't want to be seeing all those joint pains or back pains when you can be actually doing the surgery for that ankle fracture that really needs your expertise that no one else has. Next one. So why staff with emergency physicians? Same thing I've said already, but less than 10% of all those abdominal pains will actually need a surgeon. And that doesn't mean they need surgery, because many of them will be a bowel obstruction that can be managed non-surgical. And the same with, for example, less than 5% of all the patients with chest pain will need a cardiologist. So it's really important that we keep in perspective that out of everybody that comes to the ED, only a small percentage will need a specialist. And those that do, that's great that they have the care for that specialist, because they're the ones that know the best that topic. But they don't need to see the other 95% of chest pains that does not need a cardiologist. They don't need to see the other 90% of abdominal pain that doesn't need a surgeon. Next one. So emergency physicians and emergency medicine has shown to have shorter evaluation times, lower admission rates, but also lower morbidity, meaning the patients get less sick. They get better care because we know how to treat the acute condition. We also can do some observation medicine. That is when we can watch the patient, for example, for 6 or 12 hours. For example, they have a kidney stone with a lot of pain, so we can watch them for a little bit longer and see, is the pain well controlled that they can go home? Are they infected? Do they have an infection or something else? So once again, we're expert in the acute management of illness, like including stroke or acute myocardial infarction. But we're not the experts on caring for them after the acute management has started. We can send them to the cath lab, but after that, a cardiologist is the best person to care for them. We can send them for thrombolysis, but after that, a neurologist will be the best person to care for somebody with stroke. Next one. So this is two of my residents, again, teaching each other. So education and research are really the vital components of any specialty, and this is what's going to make a difference. Next one. So this is a pyramid that shows how we have different levels. At the base, we have the basic care that every hospital should have, including some basic public health services, some basic first aid, community health workers, pre-hospital first responders, and then midwife nursing, and then you need some training programs. And only after the base is ready is when you can go and look for specialties. So then we have some primary stages with specialty systems, some academic development, some educational systems, and then we keep going next to the secondary stages. So I think we're kind of here right now, and we need to go all the way to the top, where you will be making policies for the country, because we're going to be experts on the front line, and we're going to be working with our government to help them with the health policy. So that's where we should aspire to go. Next one. So again, two of the residents here. So emergency medicine continued to grow in the United States and became the most popular residency in the past, probably this was pre-COVID, that almost 1 every 5 medical students wanted to do emergency medicine. And this is why it's so important that we teach to the medical students what is emergency medicine. Also because they're going to be the ones caring for us when we get sick. So we better train those medical students, and we explain what is emergency medicine. And the person that needs to train them is an emergency physician. Again, the person that needs to train the medical students is an emergency physician. So we had high retention rates for our emergency physicians, and we had an average, this is actually sad to say, but we had an average rate of depression, divorce, and suicide compared to other specialties. And this is important, not the topic of today, but it's important that be aware that mental illness is prevalent in all medicine. And this is one more. Post-COVID, the times have changed and has become a little bit harder for some students to want to go into emergency medicine, because they have seen with all the overcrowding that is in the emergency department, why would I want to do that if that's really, you know, it's just like the example, what they're seeing today, it's just not as interesting for them. Because they also saw all the moral injury that emergency physicians and frontline providers got with COVID too. Next one. So again, this is my hospital. So it's the part where the clinic, the outpatient appointments are. So our emergency physicians teach other emergency physicians, but we also have our residents rotating other services, as well as other services come to the emergency department to learn from us. to learn what's emergency care. So they rotate in emergency. Our emergency physicians rotate, of course, in emergency medicine. They do critical care, obstetrics, orthopedic trauma, anesthesiology, emergency psychiatry, emergency neurology, pre-hospital, and ultrasound. And other specialties like orthopedics, obstetrics, psychiatry, pediatrics, anesthesia, medicine, and family medicine come and rotate with us. For example, family medicine rotate under 3 years. They have to, so first, second, and third year, you have to go to the emergency department for a month. So you get that training that you need to be a better family physician because you know how to do emergency medicine. Next one. So what are the things we teach? And this is one of our residents. They also can rotate with the helicopter crew. So we teach situational awareness. So situational awareness means that you know what's happening in the complete department, even if you have only one patient in front of you. So they need to know what's happening not only to this one, but also what about the other 10 that I'm responsible for. We teach them how to cooperate and how to collaborate with each other. And this is really critical. So my mentors for my master's thesis were a neurologist, because I was doing a stroke thesis. So I was a neurologist, an emergency physician, and an epidemiologist. Because again, we need to collaborate, we need to learn from each other. We teach them how to use and allocate resources, specifically admission. We, in emergency medicine, in my hospital, we can decide who needs admission and who doesn't. And we talk to the team, and the team accepts our decision because they know we have been trained for this and that we have a really good eye to know who's going to die, who's not going to die, and who needs to come in, who needs another care. We teach a lot about communication, and communication is more than just the verbal communication, but also how do you tell a patient that they're going to die? How you hold their hands? How do you talk to their family? How do you talk to other services? Because there is some negotiation sometimes happening, you know, because you want them to take your patient, but they're like, but we're so full, we have no beds, and we're like, oh, we have no beds either. So, you know, you need almost to kind of sell sometimes some things. We teach them leadership. And many emergency physicians in the United States have become leaders at the national level, going to work in Washington, D.C. with the government or at the regional level in each one of their states. We teach them decision-making. And that's really hard to teach. How do you teach somebody to make decisions? But we need to teach them that because we have limited information and they need to be able to re-stratify and make that decision. What's next? And we do teach them how to provide quality medical care. We want to provide good quality of care. Next one. So, although this was the case 50 years ago in the United States, emergency medicine is not the place for a recent graduate to go learn. Learn meaning like on their own and supervise. This is a place where people with experience and training should go work. We used to staff with recently graduates because no one else wanted to work in the emergency department. But that's the most the most sick and risky patient is going to be seen by the most inexperienced provider. So that does not happen anymore for many years now. You really need to have people that have formal residency training that are seen working in the emergency department. Next. So this is me with a team of people. If you look at the clock on the wall, it was midnight. So this was a New Year shift. So we were like around midnight just saying Happy New Year in the trauma bay with a group of faculty and residents and colleagues. So this is what I was saying. We're there every day because the patients don't schedule where they're going to get sick. So what do we need? So we need emergency physicians training emergency medicine residents. What else? We need a group that is dedicated to education. And I think that's something that Porto Alegre has done really well because you have good education resources. You have people that are passionate about teaching others. You have good residency programs. We need supervision of clinical work so that that resident that is learning how to be an emergency physician has somebody that's supervising them because they have the most risky job and risky patients that they're seeing. There also needs to be some accreditation because you don't want to have 200 programs, but that few are of such poor quality that you don't really know what type of residents are coming from the program. So there needs to be something that kind of some curriculum or some minimal requirements for the residency. And this recertification or continuous education is something that we do all the time, as you saw with my colleagues getting training on like a new procedure or like I haven't done a joint arthrocentesis of the ankle in a long time, so I need to practice again. And we do airway training every year because we have to be at the top of our game. We are caring for the most sick and most difficult patients. We need to be at the top of the game. We cannot let our quality of care drop. Next. I'm the research chair of my department, so I might be very biased with this, but I really feel like the research is critical and it's important to develop the specialty. But the research that I do in my hospital might be different than the research that you need here. You know, the research that everybody needs will depend on what are your needs and what's happening around. But it's really important to increase the academic recognition. And I was really excited when I hear from Juliana how many research projects are happening in the residency, because that's the way that you grow. And I'm really more excited to see that many are going to United States to present their research. Lucas has been there before, but there's many others going there now too. Research increases academic recognition, but also it will improve patient care. Next one. So we need our residents from Porto Alegre going to international meetings and presenting their research. It's not enough to just stay here. You need to send people out so that they can present outside, and we can bring the knowledge of what's happening here, there, and also you can absorb all that knowledge from outside here. What I mentioned already, what we research about, it really will depend what we need. The needs of each hospital are different. There's some national needs, but there's some things that are individual. Next one. So we're going to talk a little bit about what are the challenges of emergency medicine. So here I have one of the faculty. It's actually one of our faculty that love airway, Ben, teaching another resident who's doing an NP scope on another resident. So we teach each other, and we're also part of the models for it. So some of the challenges we have in emergency medicine in the United States are very similar to the challenges that I see that are happening here right now in Porto Alegre. So the overcrowding is a challenge. When you have patients that you want to admit to the hospital, but they stay in the ED, you cannot move them. You cannot give space for new acute patients. Those patients should leave the emergency department, should go to the inpatient floors. There is, in the same way that there could be overcrowding in the ED, there could be overcrowding in the floor. You can put patients closer together in the floor. You can put them in the hallways upstairs too. And if they're there already, you cannot close the doors of the emergency department, you know. We do have some rising cost. So emergency medicine and all healthcare in the United States is particularly extremely expensive. So this increases the cost of overall the care we provide. We do have an aging population. Baby boomers already turned 65. Baby boomers are the ones that were born after the war. And because there's older people, and we also talked before that older people are more likely to be admitted, that means also are more likely to come to the emergency department. We do have a mental health crisis. We have had an increased number of suicide, alcohol use, other drugs use, and where they come for care? To the emergency department. The same with teenagers. We're seeing a rise in teenage suicidal ideation too. And again, we are the safety net. We're the place where they go when they need acute care. We do have a substance abuse epidemic. Thankfully, opioids has not been as damaging here in Brazil as it has been in the United States. But we do have an incredible amount of people with substance abuse, heroin. People are dying for using fentanyl on the streets. That's really sad. We do have some work shortages. So after COVID, it was very difficult to retain, especially nursing staff, because they were treated poorly. They see that this emergency room is overcrowded, it's full of people. Why will I want to work there when I can work in an outpatient clinic that I might be paid similarly, but I don't get exposed to all this risk? So we need to make better working conditions for everybody, including our nurses. So the lack of resources, and I know this sounds almost funny coming from the United States, say, what lack of resources are you talking about? But the resources can get short. And then the burnout, and this is happening across all specialties and across all disciplines. Our nurses get burnout, our pharmacists get burnout, our librarians can get burnout. You know, like this can happen to everybody. And also another challenge for emergency medicine, that it will be for you too, is how to adapt to the technology and the digital interface. So we need to work with a medical record that is electronic and how we kind of interface with that. Next one. So, for example, one of the adaptations that my emergency department had to do was for psychiatric patients. So this is our pediatric emergency department where I work. So this is how the room looks regularly. But if we have a teenager with suicidal ideation, we have to make this room safe. So we close the door, almost like a garage door, so all the cords and all the safety things get behind the door. So now we have a much safer room for them. So these are small things that we need to adapt. Again, because they might be boarding in the emergency department for another day, and we need to provide a safe environment for them so that they don't hurt themselves when we're holding them. Next one. So this is another picture of the same airway training that we do every year with our faculty. These are all faculty here getting trained. So I'm just using that slide as the background. But the challenges in Brazil have been described by your own emergency physicians. So this is a paper that Lucas Silva and a team of amazing people that are, some of them are here too, wrote. So the challenges you have here are very similar to the United States, but these are also unique to you. One is recognition of emergency medicine as a specialty. And we start talking today about what is a specialty. We also talk about they also talk about how important it is to create a training curriculum despite that there is a very heterogeneous practice. So the way we practice here in Porto Alegre is different than Rio. It's different than in the northern part too. We need to foster the development of academic emergency medicine. We need a professor of emergency medicine. And it has to be emergency medicine. It has to be an emergency physician. We also need to create a research agenda that's focused on the epidemiology and the organization of emergency care. Next one. So trying to look at the future, trying to be more bright, like more positive outlook. So some of the future of emergency medicine in the world are that thankfully research has really led to advancements on the care we provide to our patients. And this has been in trauma care, in stroke management, in sepsis treatment. We do have telemedicine, and I think I have a picture after this one. We're doing telemedicine, and we have explored different ways of doing telemedicine right. So we have what we call direct to consumer, where a patient can call. But that model, it's not the one we do right now at Mayo, but we do, my emergency department covers 21 other emergency departments that are community places. They're not academic places like mine. So they can call us for help, and they can have a screen, almost like a FaceTime. Like, this is the patient, you can talk to the patient, and you can help them. For example, they can call me with a 6-year-old that is having a seizure, and they do not feel so comfortable with a pediatric patient. So how do we manage? So I will recommend some medications, and I will be there with them in the other side of the screen, like FaceTiming, that now it's something that everybody knows how to do, just helping them, giving that support. So it's 21 other emergency departments we will cover with telemedicine. We also have simulation training. You had a wonderful simulation center. We do simulation often, all the time, for the residents, for the faculty, for the team training. How do we train and work with our nurses, with our trauma surgeons? We do have some disaster preparedness. You never know when a disaster will happen, and we have to be ready for them. So we have some drills. We have drills of like an active shooter. Unfortunately, this is something that could happen in the United States with the amount of people that had guns there. But if a patient has a gun, what do you do? We have to do training for this. So we're ready when this happens. We also right now have lots of fellowships. So after you do emergency medicine, you can go to a fellowship as an emergency physician. You can do a fellowship on palliative care, on critical care, on pre-hospital, on ultrasound, research, clinical informatics, toxicology, pediatric emergency medicine, and lots more. And we have been using more and more artificial intelligence and predictive analytics. So I do have a couple of grants with companies that they're the experts in the artificial intelligence, but they need the healthcare system, they need our data, they need our expertise, and we collaborate with these companies to try to develop artificial intelligence tools. Next one. Also, that's me in the telemedicine room. So behind, you can see the map with all the emergency, these are all the sites. So this is a map of that region where I am. And we cover all those emergency departments through telemedicine. So we have several screens. So this, like, I will be looking at the screen, and you will be seeing them there. And you can see all their vital signs and the medical record, etc. Next one. So in conclusion, so you're probably hoping that this was my slides coming soon. So next one. So emergency medicine is a specialty that's coming here to stay. Next one. It's really imperative that we create the governance and the politics and the policies to promote and advance emergency care. Next one. So it will really be necessary that we allocate the resources to create high-quality standards of care, that we create the infrastructure for education, for research, and emergency medicine-specific science and knowledge. This is not internal medicine acutely happening in the ED. This is not surgery acutely happening in the ED. This is a different specialty. We have different knowledge. We do different things. We have different skills. Next one. So Brazil, Porto Alegre, must identify your own gaps on emergency care. And you need to adopt those best practices and learn from our mistakes, what we did in the United States that didn't work, and things that work. You have that opportunity to adapt that to what works for you here. And you can redesign your own model. And I promise you this one is my last slide here. So I know we will create the best emergency physicians for Brazil, in Brazil, to provide the best care possible to all Brazilians. And as I said when I started, we care for anyone, anything that comes through our door at any time. Thank you so much.
Thank you, Fernanda, for amazing talk and very inspirational. And it's an honor to have you here with us. With all you represent, especially that your institution is a huge reference for us. Nós estamos com um tempo meio curto, acho, agora, né? A Juliana ia mostrar algumas coisas que nós temos feito na emergência, bem rapidinho. E eu tinha algumas perguntas para fazer para a Fernanda e também para o Lucas, que teve a experiência de trabalhar aqui na emergência e também lá na Clínica Maio, então.
Bom dia, pessoal. Eu vou ser bem breve. Vou falar um pouquinho do que a gente está desenvolvendo na área de pesquisa ali no serviço de emergência. Basicamente, os nossos objetivos, os projetos que a gente vem desenvolvendo, têm como objetivo solucionar problemas que a gente tem no dia a dia ali no nosso serviço, né? Então, tentar melhorar questões da gestão de recursos humanos, recursos materiais, e a gente tem tentado enfocar também bastante na formação do médico residente e também dos demais residentes das demais especialidades que passam lá, das equipes multiprofissionais, com o objetivo final da gente melhorar, enfim, a assistência do paciente no nosso serviço. Pode passar, Dani. Então, atualmente, a gente tem 24 projetos em andamento. Todos esses projetos, eles foram definidos em reuniões quinzenais que a gente tem feito no último ano, basicamente. E os temas são escolhidos entre todos os residentes participam ao mesmo tempo dessas reuniões. A gente estabelece, então, metas para serem cumpridas a cada 15 dias, então eles têm que trazer um produto das metas que foram estabelecidas. E, basicamente, então, como eu havia falado antes, esses projetos estão na área de educação médica, área de gestão, área de criação de protocolos assistenciais também, alguns voltados para o desenvolvimento de pesquisa também em POCos, e temos pelo menos 2 grupos em andamento agora, um para elaboração de EPAs, para desenvolver, então, para construir o currículo baseado em competências para os médicos residentes da medicina de emergência, e um novo projeto que a gente desenvolveu agora para iniciar o desenvolvimento de treinamentos de simulação in situ na emergência, que foi um pedido dos colaboradores para a gente melhorar questões de comunicação e de resolução de situações de crise no nosso serviço. Aqui eu tenho alguns títulos dos nossos trabalhos que estão em desenvolvimento, então esses são trabalhos mais voltados para a parte de gestão, alguns deles estudando questão de indicadores da própria emergência. Pode passar, Dani. Esses 2 trabalhos são relacionados ao desenvolvimento de protocolos assistenciais. Um deles é o protocolo de via aérea aqui do hospital, que está sendo desenvolvido por um dos nossos residentes. Próximo, Dani. E esses aqui são alguns exemplos dos trabalhos que a gente está realizando na área de educação. Com a construção de EPAs, atualmente uma das residentes está desenvolvendo uma EPA para o atendimento de paciente politraumatizado. E também temos vários interessantes, mas um que tem sido, que mais recentemente o pessoal tem gostado muito, né, que é o de bloqueios anestésicos regionais, que se iniciou com treinamento e um acompanhamento antes e pós a realização do curso. Esses 2 estudos são 2 estudos de coorte que estão sendo realizados. Um é o estudo Barco, que é um estudo multicêntrico que está sendo realizado no Brasil, vários hospitais, encabeçado pelo Ian, que é um residente egresso do nosso serviço, do Serviço de Medicina de Emergência, e outro estudo de coorte que iniciou esse ano também, inicialmente no Hospital de Pronto-Socorro, que vai estudar, então, os pacientes idosos, vítimas de trauma, e a ideia é expandir esse estudo aqui para emergência, para a gente também estudar o perfil de pacientes idosos do nosso hospital, que são atendidos na nossa emergência. Pode passar, Dari. Esses são 2 produtos dessas pesquisas que foram realizadas nesses últimos 2 anos. Um deles, então, foi o desenvolvimento do carrinho de via aérea, que já está sendo também implantado em outros setores aqui do hospital, e também, mais recentemente, um artigo de meta-análise e revisão que avaliou o efeito do uso do bugie numa primeira tentativa de intubação. A gente também reativou mais recentemente o núcleo de pesquisa do Serviço de Emergência, coordenado pela professora doutora Michele Santarém, que também é chefe do Serviço de Emergência da parte de enfermagem, e a doutora Laura Fuchs, que é doutora em epidemiologia. Basicamente, esse núcleo ele serve não só para ajudar os TCRs em andamento, mas também para ajudar outros estudos que estão em andamento lá na emergência, em especial da equipe multiprofissional. E mais recentemente, então, encabeçado pelo Dr. Luiz Antônio Nazi, a gente iniciou a nossa participação na rede de pesquisa em emergência, que vai ser uma rede de estudos multicêntrico também, inicialmente aqui em Porto Alegre, de hospitais públicos e privados, que tem a residência de medicina de emergência, com o objetivo de estudar, de fazer estudos em colaboração, enfim, na área de emergência. Acho que era isso, gente, era bem rapidinho, só para mostrar para vocês o que a gente vem desenvolvendo aí na área de pesquisa na emergência, certo? Obrigada.
Muito obrigado, Ju, meus parabéns pelo teu trabalho. Eu queria só então chamar a Fernanda e o Lucas para a gente conversar rapidamente, para a gente poder fazer umas últimas perguntas só e já encerrar, né? Fernanda, thank you again. And we are a teaching hospital here, and in addition to residents, we have many medical students in our department. How important is the emergency department in the education of medical students, and how does this relationship work at Clínica Mayo?
So the medical students, as I said, are the ones that are going to be taking care of us when we're old. So medical students were the reason why emergency medicine grew in the United States, because the medical students wanted to learn more emergency medicine. They are critical. We have medical students from 2nd year, 3rd year, and some 4th year rotating in the emergency department. So all the students go at least 2 times, and they can go as an elective on their 4th year. They love it. They love it. Because emergency, when you start studying medical school, you feel that the care for the patient is so far from the education when you're in your books, but you go there and you are seeing real patients. So it's that contact with the patient and at the bedside that they really love it. It's really important to start early so that they know what is the emergency department, because that's the way we will attract more people. But also the skills that they will learn are going to be important even when they go camping. When they go camping, because they're medical students, somebody will have a bleed and they will be the ones taking care for that. But it's better that they have seen that already before. So it's critical to teach our medical students emergency medicine by an emergency physician.
Thank you. Lucas, tu tivesse a experiência de trabalhar lá na Clínica Mayo, então, com a Fernanda, e É nosso residente agora aqui do serviço, assim. Quais são as diferenças que tu enxerga que nós temos atualmente, assim, entre esses dois locais tão distintos em relação à emergência?
Primeiramente, obrigado pela oportunidade. Obrigado, Daniel. Bom, acho que a apresentação da Fernanda fala um pouco por si só, né, em algumas diferenças que ficam claras entre o que é medicina de emergência em um local onde a especialidade já é bem mais madura, né? Muitos de vocês aqui já sabem também como é que funciona uma especialidade aqui, já sabem também como é que funciona a especialidade lá fora, mas eu acho que a principal diferença é a maturidade, assim, do serviço, né? O departamento de emergência lá é composto só por médicos emergencistas, né? Todos com formação em medicina de emergência. Então, todos os professores de medicina de emergência, por exemplo, são médicos emergencistas. Então, são eles que ensinam os residentes, são eles que ensinam os estudantes de medicina. E eu acho que uma grande diferença, e talvez algo que a gente possa tentar incorporar, assim, é os contratados, os professores, eles realmente eles vestem a camisa do serviço, porque eu acho que é isso que faz o serviço crescer, né? A gente precisa colaborar como grupo, a gente precisa ter os contratados em sintonia com os residentes, com os estudantes de medicina, para que realmente a medicina de emergência possa crescer. E eu queria só fazer um comentário, assim, eu acabei ficando quase 3 anos lá, então convivi muito com a residência lá também. E quando eu voltei, eu sempre ficava com essa ideia de que, eu vou voltar e aqui vai ser pior. E eu me surpreendi, na verdade, positivamente. Talvez por Porto Alegre ser o berço da especialidade, mas a qualidade da nossa residência aqui ela é muito boa. A qualidade das pessoas, dos médicos emergencistas e dos residentes de medicina de emergência, eu sempre ficava pensando assim, sabe, quando eu voltar para o Brasil, será que o meu R+, vai ser tão bom quanto era o R+, lá na Mayo? E quando eu cheguei aqui eu vi que eles eram muito bons. Então eu acho que a gente tem que ser otimista, né, sobre o futuro. E talvez tentar se espelhar, assim, é bom a gente ver, assim, uma luz no fim do túnel e ver, assim, como a gente pode melhorar, né, para poder setar alguns objetivos. Acho que é isso. Muito obrigado.
Obrigado a todos, então, pela presença. Acho que nós encerramos, passamos um pouquinho da hora, mas agradecemos muito a presença de todos, presencial e online.